Okay, thank you for my introduction. In today's talk, I would like to focus on several aspects of human milk fortification and on how to meet the protein and energy requirements of preterm infants receiving human milk. First of all, these are my disclosures. I do give some lectures in collaboration with several nutritional companies, but I do not have a specific preference or personal benefit for any brand. The only nutritional source I always recommend is mother's own milk. First of all, let's take a look at what is required for healthy growth. Of course, nutrition is required, and this encompasses protein, energy to finance the cost of protein synthesis, essential fatty acids, and all micronutrients, of which especially phosphate has gained more interest in neonatal nutrition in the last few years. But besides nutrition, oxygen is required to facilitate energy generation and anabolic hormones, which are usually not present in large extent while an infant is critically ill and suffering inflammation. So knowing all this, we can take a look at achieved growth curves from preterm infants. Unfortunately, there is still a major gap for many infants if intrauterine growth is compared to growth once the preterm infant is born preterm and admitted to a neonatal intensive care unit. On the left, two well-known studies are shown, where you can see that preterm infants fall off the growth curve from what would have been achieved while still in utero. Over the years, this has only improved slightly. And in the table on the right, you can see that also recently discharged infants from 11 European countries still lose about 1.2 standard deviations when compared to their birth standard deviation. 14% of the discharged infants even lost more than 2 standard deviations when compared to birth. On the other hand, there are also some reports of usually single centers that after paying meticulous attention to nutrition and growth, this fall in the growth curve can be prevented in the majority of preterm infants. When assessing growth, it is of course always wise to assess intake as well. And while there is still a firm belief that own mother's milk from women that delivered preterm contains more protein than from women that delivered around term gestation, this is actually only the case in the first few days, as can be seen in this meta-analysis from a few years ago. Both in milk destined for preterm and term infants, it can be seen that the protein content decreases rapidly after the first few days, and it stabilizes, or in the weeks, and it stabilizes around 1 gram per deciliter. This graph comes from a more recent, very large study, the premature milk study, in which over 1900 milk samples were analyzed. A similar picture was seen. After 2 to 3 weeks of life, the average milk protein content amounted barely 1 gram per deciliter. But you can also see from the percentile lines that there is a very wide variation, which makes, of course, assumptions in daily practice very difficult if milk is not regularly measured for the macronutrient content. And partly because of this very wide variation in for example, the protein content, multi-nutrient fortifiers have always been on the safe side in order not to provide too much protein. So if, for example, in this graph, we extrapolate what the addition of an average fortifier would do when adding 1.2 gram per deciliter of protein, we see that the graph goes up, of course. If we then convert what this protein content translates into daily milk consumption, one can infer that around day 10 of life, the infant receives an average of about 3.5 to 4.3 gram of protein per kilogram per day. This coincides with most recommendations, which advise around 3.5 to 4.5 grams of protein per kilogram per day. However, after 4 weeks of age, this amount has decreased to about 3.5 of protein per kilogram per day, which might not be enough for many infants admitted to the neonatal intensive care unit. So let's take a look at how protein requirements are defined in the literature. First of all, one can take a factorial or a theoretical approach. This means nothing more than one calculates of how much protein is actually deposited in newly formed tissue at a growth rate that is similar to the intrauterine growth rate. Besides, some inefficiency factors are then added. All in all, approximately 4 grams per kilogram per day of enteral protein is assumed to be required for achieving a desired growth rate of about 15 to 20 grams per kilogram per day. But if you like to base protein requirements on experimental evidence, you can take a look, for example, at the Cochrane review on fortification. While this may seem promising at first sight, as almost 1,500 infants are assessed in 18 RCTs, results are a little satisfactory. The authors concluded there were some modest increases in several growth rates, and besides, it was reassuring that no adverse effects of fortification were seen, like necrotizing enterocolitis. But on the other hand, also no long-term benefits were demonstrated. But this outcome was only studied very sparsely and thus highly underpowered. Besides that, there were also several other limitations. In that, for example, the range of added protein was low. Relatively old studies were included with suboptimal design, as you can see in the right graph. And many studies also included only moderately preterm infants and were performed in low and middle income countries. This all hampers drawing very firm conclusions. In fact, many Cochranes have appeared since 2018, all on the subject of human milk fortification for preterm infants. Unfortunately, all these reviews have not revealed many answers. This was mainly due to a lack of proper studies. But what we do know is that poor growth is associated with poor neurodevelopmental outcome. These relationships remain valid also after statistical adjustments of confounders like sepsis or necrotizing enterocolitis or many other background variables. Unfortunately, no well-powered, well-conducted, true experimental RCTs in human milk-fed preterm infants have been performed. Thus, evidence that more nutrients and better growth results also in a better long-term outcome is limited. On the other hand, there is some evidence from a well-known RCT on infants who were partially formula-fed. In this trial from the 1980s, over 400 infants were randomized to receive in the first 4 postnatal weeks either human milk supplemented with regular term formula if human milk was insufficient or unavailable, or a newly designed preterm formula with more nutrients. And what they saw in the many years of follow-up was that those in the intervention group not only grew better, but also had persistent improved neurological outcomes up to the age of 16 years. Since it is very clear that unfortified human milk results in poor postnatal growth, it is advised by ESPGHAN, the European Milk Bank Organization, the European Parental Organization, and the American Academy of Pediatrics that for all preterm infants, a multi-nutrient fortifier is added to human milk. There are, however, many types of multi-nutrient fortifiers available. These fortifiers are usually from a bovine origin, from the cow. However, there is also a fortifier available that is produced from condensed donor human milk. This could bring the advantage of a so-called human-only diet. However, this approach is not firmly evidence-based. In fact, the only RCT which studied this particular approach by O'Connor a few years ago in AGCN did not show, for example, a reduced NEC or sepsis rate. But the study was relatively small. Much more independent research and evidence is needed before this approach of the human milk-based fortifier should be recommended, in my view. Also, because there are significant drawbacks in this approach, because depending on the strength of applied fortification, 20 to 50% of the mother's own milk volume is displaced by this liquid fortifier. Besides, there are significant costs to this approach, and one may ask questions to the ethics and feasibility of this approach, especially if applied throughout the world. Bovine fortifiers may then be divided into powdered and liquid fortifiers. In the US, powdered fortifiers are not used routinely due to the fear of a chronobacter infection. Over there, liquid fortifiers are routinely used, which also have the drawback of volume displacement of human milk, typically about 20% reduction. But if we then look at the powdered formulas, fortifiers again, these may be subdivided into common or in newer generation fortifiers. Even bovine colostrum fortifiers are being developed. These first two fortifiers are typed whether carbohydrates or lipids form the main non-protein energy source. And fortifiers from bovine colostrum are currently only tested in trials in Denmark and in China. And if we take a look at these first two types of regular powdered fortifiers, you can see that these fortifiers typically contain about 1 gram of protein that is added to 100 ml of human milk. The remainder is then made up of carbohydrates and other micronutrients, especially the minerals phosphate and calcium. However, in the newer type of fortifiers, protein content is usually a little higher and the carbohydrates are largely replaced with lipids, sometimes also with small amounts of the long-chain polyunsaturated fatty acids. So we have seen different types of fortifiers, but there are of course also many strategies how to use these fortifiers in practice. Well, first of all, there is of course the standard fortification, where a powdered or a liquid multi-nutrient fortifier is added to the milk. Some clinics then also give some extra supplement if donor milk is used because of the low protein and lipid content. So modular protein and lipids are added. Growth is then assessed, and if the growth is normal, everything is fine. But if growth is poor, then some clinics choose to add more multi-nutrient fortification or modular protein and lipids. Others accept the poor growth. But also in the literature, you can also find more about individualized fortification, and this is divided into two types: adjustable fortification and targeted. Adjustable fortification means that it is dependent on the measured level of the serum urea concentration. So a standard fortifier is added, sometimes for a supplement for in case of donor milk is used, and then depending on the once or twice a week urea, the level of fortifier is brought down, or more proteins are added if the urea is low. However, these cutoff levels for the urea are not really evidence-based, and it comes with the disadvantage that you require regular blood sampling. A newer approach is the targeted fortification, where the macronutrient content is measured 1 to 3 times a week, and based on those levels of the lipids, the carbohydrates, and the protein, more or less protein and lipids is actually added to the milk. So this is truly individualized based to the level that one wishes to desire. This, of course, requires an expensive milk analyzer, and it requires a few mLs of milk each time it is measured. It is also just time-consuming, and it needs a dedicated team. But research is showing that you can really optimize the nutritional intake in these infants. So, with that having said, I'd like to finish with these conclusions and recommendations. Preterm birth is, of course, a nutritional emergency. We all know that. Mother's own milk is the best source of nutrition for preterm infants, provided it is fortified with a multi-nutrient fortifier. The human milk protein content decreases within 2 to 4 weeks to about 1 gram per deciliter, and donor milk might even be lower in protein and lipid content. So, standard nutrient fortification may not provide sufficient protein intake in the range of 3.5 to especially 4.5 gram per kilogram per day, but that the optimal fortification strategies are unfortunately relatively poorly studied, and topics of debate mainly include whether to start early or late, whether you act as a standard or adjustable or targeted fortification, whether you should use a bovine or human origin fortifier, or if you should use a powdered or a liquid fortifier. Thank you for your attention.